Good evening, everyone.
Thank you for joining us as we talk about asthma in the new era. I would like to introduce Dr. Sylvia van der Berg. She is our head of the immunology department at our NRL lab in Centurion. Thank you, Dr. Sylvia.
Thank you, Yolandi. Good evening, everyone. Thank you for joining us today. Over the past decade, we've really witnessed a major shift in asthma management. We've really moved away from treating all asthma as just a single disorder, and we are moving towards precision medicine, where we actually now identify the underlying inflammatory pathway, and then we tailor treatment to the individual patient. So we're going to give Prof. Andre van Niekerk the opportunity to explain these inflammatory pathways to us. Andre is a pediatrician and pediatric pulmonologist with an interest in clinical immunology. He previously served as a chairperson of the Allergy Society of South Africa, ULSA, and currently leads the ULSA Primary Immune Deficiency Diseases Interest Group, PITSA. He is a founding member of the Allergy and Clinical Immunology Foundation of South Africa, AFSA. He spent much of his career in private practice, but remained involved in academic medicine and contributed to the development of a clinical service for primary immune deficiency diseases at the University of Pretoria. He later returned to full-time academic work within the Department of Pediatric and Immunology. He currently holds the University of Pretoria Ampath Chair for Inborn Errors of Immunity and Allergology and is the Associate Director of the Inspire Focus Center of Excellence for Clinical Immunology. He also serves on the boards of the African Society for Immunodeficiencies and the South African Immunology Society. Welcome, Andre, and thank you. We are looking forward to understanding T2 inflammation better.
Thank you, Sylvia. Thank you for the invite. You really gave me a hard time here. I have to explain a huge topic in 20 minutes. So I'm going to be brief and hopefully not confuse you at all. But everybody should know that I have received speaker honoraria from AstraZeneca, Sanofi, and Glenmark in the past, and that I am the University of Pretoria Ampath Chair for Inborn Errors of Immunity. So what I wanted to do is just briefly set the scene first, then focus and zoom in on the key concepts of T2 inflammation. And if you haven't heard this yet, T2 inflammation is big news. So I'll try and make it as easy as possible. And as a clinician, just briefly elaborate on the relevance of T2 inflammation. I won't have time to go through all of it, but really just tease you a bit with T2 inflammation. Now, Sylvia has already said this. We come out of a decade of new technology, new DNA-based technology, new diagnostics, and we are now no longer basing diagnosis just simply on symptoms. We are really, through the use of biomarkers and a better understanding of the underlying immunopathology, understanding diseases much better. And remember that asthma is an immune disease. So that's why asthma is such good news for us. And in the future, we are going to not just simply diagnose asthma based on symptoms. And as Sylvia already said, we are not simply going to prescribe based on symptoms, because what we think may work may not work. And what we think may work may actually be harmful in some patients. Now, two big discoveries that we must remember is that in this last decade and a half, we've discovered through the new technology that epithelial cells are actually immune cells. They're not simply barrier cells. And epithelial cells actually have the ability to signal through specialized receptors and cytokines and trigger inflammatory responses, the cells themselves, including T2 inflammation. So just remember this, epithelial cells are important, and I'll show you in a moment why they are important. Another new exciting cell that was discovered is the ILC cell. So ILCs, or innate lymphoid cells, These are lymphocytes, but they are lymphocytes without receptors. So they're not T cells or B cells. They don't have a receptor. And remember that the lymphocyte uses that receptor to identify a specific protein or antigen. So they can't identify specific antigens. But these lymphocytes respond to alarmins or cytokine signals that they receive rather than responding to a specific antigen. And like helper lymphocytes, they then secrete a panel of cytokines that drives the inflammation. So just remember the ILCs. We're going to talk about them again in a moment. Now, lots and lots been discovered, and that resulted in this paper being published a year or two ago. And this is the new nomenclature on allergic diseases, hypersensitivity reactions, our new understanding of hypersensitivity reactions. And the next slide is meant to shock you. So if you have a look at this slide, I'm really not going to talk you through it, so relax about the slide. But I wanted to point out a couple of things. You know, in the old days, we learned about Jolin-Coombs and the 4 hypersensitivity reactions, the type 1, 2, 3, and 4 reactions. And if you still struggle with them, forget about them, because we've now got 9 hypersensitivity reactions. And basically what happened is that the type 4 hypersensitivity reactions, or cell-mediated hypersensitivity reactions, they've now been subclassified or defined into 3 types, T1, T2, T3, or type 4A, 4B, 4C hypersensitivity reactions. We're going to come back to them. So we've now got different types of cell-mediated hypersensitivity reactions. And then if you look to the right-hand side of the screen there, we now acknowledge the epithelial cells as important in driving hypersensitivity. And another column to the right, type 6, we now acknowledge that the human microbiome plays an important role in hypersensitivity. Now, each one of these 9 columns, if you've got time, I really want you to have a look at them. Each one of these 9 columns, they come with their own unique set of effector cells and their own unique set of cytokines that drives that specific type of hypersensitivity reaction. And why is that important? It's important because it means that we can now identify different endotypes of hypersensitivity, and we can now target specific targets in each one of these columns, target specific cells or target specific cytokines or receptors within each one of these columns. Now, back to that 9 columns, I've underlined for you there asthma, and have a look. Asthma falls into 1, 2, 3, 4, 5, 6 of these columns. In other words, there are 6 potential different types of inflammation that can drive the symptoms of asthma as we know it in our practices. Now, don't get stressed. We're not going to go through each one of the 6. All you need to remember is that for a clinician, before we even start treating an asthmatic patient, I should actually be able to write on my file, this is a type 2 asthmatic or it is a non-type 2 asthmatic. Allow me to explain. Just choose between the 2. It's either type 2 asthmatic or it's a non-type 2 asthmatic. So what is type 2? Type 2 is important because type 2 asthmatics are the patients that we will most frequently encounter in our practices. Not all asthmatics are type 2 asthmatics, but they're most frequent and they often suffer from more severe asthma, the type 2 asthmatics. Now, where does type 2 come in? And we need to remember this. In our body, we've got healthy inflammation. Not all inflammation is bad. Inflammation is good for you. You need inflammation. You need inflammation for healing. You need inflammation to develop immune memory. And not all inflammation is bad. But inflammation can become aberrant or chronic, and that's a problem. When the immune system fails to fire down, or if the immune system fails to contract, that's a problem. Now, there are three types of healthy inflammation: T1, T2, and T3 healthy inflammation. And what I wanted to show you on this is that each one of these types of inflammation has got its own innate immune cells that play a major role in that type of inflammation. Each one of them has got its own adaptive immune cells that play a role. Remember the adaptive immune cells, for example, producing antibodies. Each one of them, its own adaptive immune cells. And each one of these types of inflammation driven by a set or a panel of cytokines. So this is what differentiates the types of inflammation. Now just look at type 2 there. Type 2 is the one where we're dealing with basophils, mast cells, and eosinophils, and B cells producing IgE. And these are the cytokines driving type 2 inflammation. So what does healthy type 2 inflammation do? And healthy type 2 inflammation is what defends us against parasites, against helminths. So if you've got a worm in your gut, what's a great way of getting rid of it? Use your eosinophils, your mast cells, and IgE. And what that drives is really the production of mucus. I'll show you in a moment, to line that helminth with a nice layer of mucus. It's an inflammation that stimulates smooth muscle so that you can literally contract your gut more, and you can get rid of that helminth after you lined it with some mucus. But if healthy inflammation goes wrong, then we get disease. Before we look at what happens if it goes wrong, just look at T1 inflammation. T1 inflammation is what's supposed to protect us against intracellular pathogens, the small things, the viruses, mycobacteria, and the atypical microbes. And what does T3 do in an healthy individual? It's what protects us mainly against bacteria and fungi. That's what it's supposed to do. But see what happens if it goes wrong. If T2 goes wrong, then we develop allergic rhinitis with eosinophils and polyps, atopic dermatitis, eosinophilic esophagitis, even anaphylaxis and asthma. T3 can also cause non-type 2 asthma, and we know that's also the case with T1. But these are conditions that are typically associated with the inflammation when it goes wrong. Now, let's go back to that graph that I showed, the summary that I showed you. If you look at type 1 hypersensitivity reactions, these are the typical cytokines and cells and mediators. And if you move over there to type 4B hypersensitivity reactions, you will see that they are duplicated. Many of them overlap between a type 1 and a type 4B hypersensitivity reaction. And if we then have these two inflammatory processes going on, it steers us towards type 2 inflammation. And I just wanted to quickly show you here, epithelial cells. There are certain cytokines, or alarmins we call them here, that epithelial cells produce that I want to show you in a moment. But remember, if you've got an asthmatic patient, we want to distinguish, is this a T2 type of aberrant inflammation that I'm dealing with, or is this a patient with non-T2 aberrant inflammation? So if it's a non-T2 type of asthmatic patient, it's usually the T1 and T3 types of inflammation that went wrong. Those are the cells usually associated with them. And if it's a T2 endotype, then it's those cells that I mentioned already that went wrong. The eosinophils, the mast cells, basophils, those are the cells that normally went wrong, mainly eosinophils. And you will see that the type 2 endotype is the endotype that I've mentioned already that we see more frequently and more in asthmatics. Now, this is a nice diagram, infographic of type 2 inflammation. And if you show me an infographic like this, it's almost like shooting me. It's almost like death by immunology. And that's really not what I want to commit tonight. So what I'm going to do is I try to make it easier with my own cartoon. And unfortunately, I can't use animation. So we'll need to focus a bit. So in the old days, we're talking about the type 1 hypersensitivity reaction. And in the old days, we were taught that We've got an allergen. That the allergen is processed, the information of the allergen is processed by the T helper cell and specifically skewed towards the Th2 helper cell. There are the cytokines that I mentioned before, and it drives the B cell to produce specific IgE against the allergen that lines the mast cell and cross-linking it in future, and you've got mast cell degranulation, histamine release, tryptase release, etc. So this is the classic type 1 Jalen-Coombs hypersensitivity reaction. But what have we learned in the meantime? We've learned in the meantime that the epithelial cell plays a role. And if I stress an epithelial cell with pollutants or with a virus, for example, those epithelial cells release alarmins. And these alarmins, and remember I showed you on the previous slide, IL-25, IL-35, TSLP is important, TSLP is important. And those alarmins activate the innate lymphoid cell. Remember the ILC cells that I got excited about. And see what they do. They produce the same cytokines as what we see in the classic type 1 hypersensitivity part to recruit eosinophils, and especially IL-5, recruiting eosinophils. And many of these cells also produce IL-13. That's part of the T2 panel. Remember I mentioned IL-4, IL-5, IL-13, part of the T2 panel of cytokines driving this inflammatory profile. And see what IL-13 is up to. IL-13 drives more mucus production, more scarring, more hyperreactivity, and IL-13 drives the production of exhaled nitric oxide. In other words, nitric oxide in the airway through the inflammatory process. So let's just tease you a little bit. If I've got a patient and I measure the IgE and it's normal, and I measure the specific IgE and it's low, can this patient still suffer from T2 inflammation? And the answer is yes, because it could be eosinophils. That's the main thing to actually focus on. So just measuring one thing, like IgE, for example, or just measuring eosinophils could deceive us because they all involved in this process. And if this is more dominant, then eosinophils may dominate, for example, in that T2 process that the patient is facing. What does this mean in clinical practice? It means that I've now got markers that I can use, and Sylvia is going to talk to us about the biomarkers. So I can now in clinical practice measure eosinophils and form an opinion, is this T2 inflammation that I'm dealing with or not? Remember, if it's T3, it will be neutrophils that will be dominating. But if it's T2, eosinophils will be dominating. And if it's T2, FeNO will be increased. Nitric oxide in the airway that we can measure effectively will be increased. And markers like IgE could also advise us that we are actually dealing with T2 inflammation, but Sylvia is going to show us that. And just a brief summary here, I've already said it. IL-4 drives the B cells to produce more IgE or specific IgE. IL-13, the mucus producer, the collagen deposer, the smooth muscle hyperreactivity is driven by IL-13. And IL-5, the eosinophil recruiter, and the cytokine that helps eosinophils survive. What does this mean in clinical practice for me? If I've got a patient with dominant eosinophilic disease, I can just block IL-5, and that's possible. Or I can block IL-4 and IL-30, but choose to block them. And by just blocking them, I can reduce T2 inflammation significantly without causing harm to any of the other cells in the body of the patient. So what's the clinical relevance of understanding T2 inflammation? In other words, why is it relevant for us to decide a patient has got T2 or non-T2 asthma? What is the relevance of that? We don't have time to go through all of it, but I just want to touch on a couple of highlights. First of all, T2 inflammation, and we now know it's driven by eosinophils, it's driven by basophils, by mast cells, and it's got a very specific clinical picture. So just opening our eyes and looking at the patient, we can actually often see T2 inflammation, because T2 inflammation has got characteristic clinical features. If I look on the skin, for example, this is atopic dermatitis, T2 inflammation that I see there, typical in the flexural folds. You can see the itching, the patient is scratching, the scarring, that typically goes with T2 inflammation on the skin. So if you see a patient and the patient has got this typical clinical feature on the outside of the body, but he's got airway complaints as well, then you can start thinking, what's going on in the lungs? Clinically, I see outside T2, so most likely T2 happening inside the lungs as well of this patient. The patient with allergic rhinitis, that's sneezing, it's itching once again, the teary, itchy eyes, typical features of allergic rhinitis. If I can see that on the face of the patient, the typical symptoms of T2 inflammation, then I should also think that this is most likely what's going on in the lungs if the patient is asthmatic. But if it's a patient that's got asthma symptoms only, I don't see any of these other features clinically on the patient, I need to start doing biomarkers, because it's not possible for me to assess what's going on inside the lungs directly. So I need to start doing the markers of T2 inflammation in this patient. Now, the new diagnostic guidelines for asthma in children is becoming more and more adamant that we've entered a new era in asthma management in patients. You know, in the old days, we used to say it's a clinical diagnosis. You listen to a story and you make a clinical diagnosis, and that is no longer acceptable. This is the new European guideline that calls for at least 2 objective measurements before an asthma diagnosis may be made. In other words, I need to at least have spirometry, that's a measurement that supports it, or bronchodilator reversibility testing that supports asthma, and now the biomarkers. The FeNO, for example, exhaled nitric oxide biomarkers. I need at least 2 biomarkers, preferably 2 markers, preferably, before I should document or diagnose, label a patient as an asthmatic patient. And what is very important, and I'll show it in a moment, is that I should actually do this before committing a patient to steroid therapy, because steroid therapy affects the biomarkers. And if I start steroid therapy before doing the biomarkers, I miss these objective measures, and that has got long-term consequences. How good are these biomarkers, like measuring eosinophils and measuring exhaled nitric oxide? This is a very important study, and it's a study that looked at the risk factors for asthma attacks in patients. And you will see up here, I know it's small, but the blood eosinophil count, interpreted the correct way, has got a high level of certainty of risk for the patient. Or the FeNO, the higher the exhaled nitric oxide increase, the higher the risk of the patient suffering a severe asthma exacerbation. And if we look at things like that we traditionally relied on, like bronchodilator reversibility, you will see that the certainty of level of certainty that this patient is in big trouble is actually less than the level of certainty for a patient with these high biomarkers. So that's another reason to look at the biomarkers, is because they warn us of risk in the asthmatic patient. And this is what I've just said in a graphic representation. Look at this. Our estimated annualized severe asthma risk attack rate. If the FeNO is high, 50, the pink band there, you can see that it's directly related to the risk of a severe asthma exacerbation. Same for eosinophils here at the bottom. Now, so T2 biomarkers is also a warning of not only risk, but also a warning of complications. Why? Because T2 patients are patients who typically respond very well to corticosteroids. So if you give them corticosteroids, it makes a difference. And harm in asthma is caused by uncontrolled T2 inflammation, that causes harm in asthma. Why does it cause harm in asthma? Because first of all, it results in loss of lung function. Every asthma attack loses lung function going forward. And it results in asthma exacerbations. And then what do? We give bursts of systemic corticosteroids. And we are now concerned about repeated use of short courses of corticosteroids in patients. So we can use our T2 biomarkers to actually warn us whether T2 inflammation is controlled or not controlled, and whether it will result in unnecessary corticosteroid use or avoidable corticosteroid use, and whether we are actually causing harm in a patient. So a patient that's on inhaler therapy, but the FeNO remains high or the T2 biomarkers remains high, that's a problem, and we need to review that. And this is important about the eosinophils. Many, many years ago, 1958, Harry Morrow Brown already showed us that if a patient has asthma and the eosinophil numbers are larger in the sputum, they respond to corticosteroids. But if the eosinophil numbers are low in the sputum, they don't respond well to corticosteroids. They only get side effects. They don't respond in terms of the treatment of their disease. And why is this? That initial graph that I showed you, what do corticosteroids do? They kill eosinophils. They suppress IgE production by about 20%. They suppress this whole cascade. But they also suppress T1, and they also suppress T17. In other words, neutrophil counts go up when you give corticosteroids in patients, and macrophage function comes down. So let's say this is a patient with cough and wheeze, and it's a young child. You're not sure if it's asthma. It could be a viral infection, and you give him corticosteroids. You're going to kill his eosinophils, but this is actually a viral infection instead of an eosinophilic asthma attack. And what are you going to do? You're going to reduce his defense, and you're not going to treat his asthma symptoms that he's having. Now, I need to start wrapping it up, but I wanted to show you this. We can now predict, there are certain predictors on whether a child will outgrow asthma or not. And parents ask us those questions. Will my child outgrow his asthma or not? Now, the most sensitive predictor, and we're now talking about children in their primary school age years, is the FEV1 FVC ratio. What was my FEV1 FVC ratio when I was in primary school? And if that ratio was low, you can see how bad the outcome is in terms of outgrowing asthma in future. But if that ratio was on the better side, we use the eosinophil count to actually predict whether the patient is going to outgrow asthma or not. And remember what I said, if you're given steroids, you are suppressing the eosinophil count. So there's a big call at this stage that we should measure these baseline things, like the FEV1 FVC ratio, the spirogram, and the biomarkers, preferably before we start treating patients with high doses or repeated doses of steroids. So do the baselines, and if it's a T2 inflammation, you know that your patient will respond to steroids. And just lastly, this is what we're using now to actually decide when we're using these biologics, the new era of anti-inflammatory treatment in asthmatic patients. So we're looking at things like the eosinophil count, the FeNO. I haven't got time to go into the detail. And that guides us in terms of that, together with the clinical picture that I'm seeing. Is this a patient with asthma and chronic urticaria, or a patient with asthma and nasal polyps? That will guide us in terms of which specific biologic we are going to use in this patient. So I need to wrap it up, and I'm sorry if I rushed it a bit, but Sylvia is going to discuss this, just to say that we should document whether patients have T2 or non-T2 asthma, as that will result in our decision on terms of treatment. It will help us optimize our anti-inflammatory control. It will help us with more accurate drug selection. We can predict the future of the patient. It gives us a prognostic indication. And if we measure biomarkers, we stop using unnecessary steroids, and we want to reduce steroid use, and we prevent the need for oral corticosteroids by increasing our inhaled steroids in time before there's need for oral corticosteroids. Sylvia, I'm going to stop it there. I'm happy to take questions afterwards. Maybe you should speak first, and then hopefully you can clarify some of the confusion that I caused.
Thank you, Andre, for explaining a very complex pathway and immunological pathway really so eloquently. So today I'm going to talk to you about understanding type 2 biomarkers better. And we're not just going to talk about what they are, but how you can actually use them in your everyday practice to improve your asthma management. So let's first look at what we mean with type 2 biomarkers. Type 2 biomarkers are measurable indicators of type 2 inflammation. That's the inflammatory pathway driven predominantly by the cytokines interleukin 4, interleukin 5, and interleukin 13. And rather than just telling us that the patient has asthma, these biomarkers really help us understand what type of inflammation is driving the disease. And this is important because not all asthma is the same. Some patients, like you've heard, have type 2 high inflammation, while others have type 2 low disease or neutrophilic disease. And it's important because these groups respond very differently to treatment. These biomarkers play an important role in not just diagnosing asthma, but it can also identify patients with other type 2 inflammatory disorders, such as allergic rhinitis, eosinophilic esophagitis, and atopic dermatitis. But perhaps most importantly, they have transformed asthma management. Instead of just treating all the patients the same, we actually now identify those with type 2 inflammation. We predict who is most likely to respond to corticosteroid therapy, or perhaps are they candidates for biologic therapies, and we can use these to monitor the response over time. Before the era of biomarkers, we tended to treat all asthma in much the same way. We basically focused on the patient's symptoms and the lung function, and we basically used the same treatment pathway. But we now recognize that asthma is not a single disease. It can be a collection of different diseases driven by different inflammatory pathways. So rather than just simply treating the symptoms, we now aim to identify and treat the underlying endotype. So to understand this, it's really important to distinguish between a phenotype and an endotype. A phenotype describes what we can observe, the patient's clinical characteristics, the symptoms, the measurable features. For example, we see a patient and they have allergic asthma, or they have exercise-induced asthma, or obesity-associated asthma. An endotype, on the other hand, explains why the disease occurs. It describes the underlying biologic mechanism driving all these clinical features. In asthma, this may be type 2 high inflammation driven by the cytokines interleukin 4, 5, and 13, or it can be type 2 low or neutrophilic asthma involving other pathways such as interleukin 17 or interferon gamma. So I like this analogy of an iceberg. The phenotype is the part of the iceberg that we can see above the water. That is the patient's symptoms and the clinical presentation. But the endotype is this much larger structure hidden beneath the surface of the water that explains why this iceberg looks the way it does. The important point is that a patient with the same phenotype might actually have different endotypes, and then patients with different phenotypes might actually share the same endotype. So it's the endotype that we need to determine and need to understand to recognize which targeted therapy is most likely to work. So biomarkers help us to diagnose asthma. It identifies type 2 inflammation. It predicts risk of future exacerbations. It helps us select the most appropriate biologic therapy, and it helps us monitoring treatment response over time. So they allow us to move beyond a one-size-fits-all approach and really to help us make precision-driven decisions. It helps us stratify patients according to their inflammatory profile, and it identifies patients with type 2 inflammation. It helps us predict the risk of future exacerbations, monitor disease activity over time, and also assess how well a patient is responding. So ultimately, it allows us to personalize asthma management. So before we discuss the biomarkers, it is important that you understand these pathways that Prof has explained to us so nicely. Type 2 inflammation is the most common inflammatory pathway in asthma, and it is driven by the three cytokines, interleukin-4, interleukin-5, and interleukin-13. These cytokines are produced by T helper 2 lymphocytes and type 2 innate lymphoid cells, or the ILC2s. And these cells orchestrate this whole type 2 immune response. Each cytokine has its own distinct role. Interleukin-4 drives IgE production and promotes allergen sensitization. Interleukin-5 is the key cytokine driving eosinophil growth, recruitment, and survival. Interleukin-13 contributes to mucus production, airway hyperresponsiveness, and also stimulates nitric oxide, which is why FeNO is such a useful biomarker. The result of this whole immune response is eosinophilic airway inflammation, an increase in IgE production, elevated nitric oxide levels, and airway hyperresponsiveness, the hallmarks of type 2 asthma. So, and this is exactly what we measure with our type 2 biomarkers. It also helps us understand the pathways that we're actually targeting with our biologics, such as interleukin-4, interleukin-5, interleukin-13, or IgE blockers. Now, let's look at the biomarkers we can use to measure in clinical practice. But before I do that, I'd just like to point out the picture in the top left corner, which is the Ampath National Reference Laboratory in Pretoria, where many of the specialized immunology and allergy tests are performed. So as you can see, we have several biomarkers available, each requiring a different type of sample. Blood eosinophils are measured from a routine EDTA blood sample provided on the differential count of the full blood count. FeNO is measured from a breath sample. Allergen-specific IgE is measured in serum, and sputum eosinophils are obtained from an induced sputum sample. Finally, you'll also notice the marker periostin. It's an extracellular matrix protein induced by interleukin-13. While it showed promise as a biomarker, it really has largely remained a research tool and is not routinely used in clinical practice. So the first biomarker I'm going to discuss is the blood eosinophil count. When interpreting blood eosinophil counts, it is important to distinguish between diagnosis and treatment decisions. A blood eosinophil count above the laboratory reference interval is considered elevated. In patients with severe asthma, the Global Initiative for Asthma Strategy, the GINA strategy, identifies a blood eosinophil count of more than 0.15 times 10 to the power 9 cells per liter as evidence supporting type 2 inflammation. For selecting patients for type 2 targeted biologic therapies, a threshold of more than 0.3 is commonly used, although this cutoff really varies according to the specific biologic that you're using. But never interpret eosinophils in isolation. An elevated eosinophil count certainly supports type 2 inflammation, but it is not specific for asthma. There are several other conditions associated with eosinophilia, including allergic disease, helminthic infections, eosinophilic granulomatosis with polyangiitis, or Church-Strauss as we know it, drug reactions, and the hypereosinophilic syndromes. It's also important to remember, and Prof has highlighted this to you, that eosinophils can be suppressed by corticosteroids, and it can also be transiently reduced by acute infections. So among the currently available biomarkers, fractional exhaled nitric oxide, or FeNO, has emerged as one of the most useful point-of-care tests for assessing type 2 airway inflammation. It is non-invasive, provides results within minutes, and reflects ongoing eosinophilic airway inflammation. It measures the concentration of nitric oxide in exhaled breath, expressed in parts per billion. This test is performed by having the patient exhale at a constant flow rate into a handheld analyzer fitted with a disposable fitted container mouthpiece. Because of its simplicity, its rapid turnaround time, and the ability to identify type 2 inflammation, it really has become an important tool in asthma management. The updated NICE guidelines of 2024 recommend FeNO as part of first-line testing to help confirm a diagnosis of asthma. And it's also recommended that you use FeNO during routine asthma review to monitor the airway inflammation and to guide your treatment decisions. Let's look at how we interpret FeNO. In general, a FeNO level below 25 parts per billion is considered low, suggesting that significant type 2 inflammation is unlikely. Values between 25 and 50 parts per billion fall into an intermediate range, and these results need to be interpreted in the context of the patient's clinical symptoms, the treatment, and other biomarkers such as eosinophils. A FeNO level above 50 parts per billion is considered high and strongly suggests ongoing type 2 airway inflammation. But again, it is important to remember that FeNO is influenced by inhaled corticosteroid therapy. Corticosteroids suppress nitric oxide production, so the threshold for an elevated FeNO becomes lower as the dose of inhaled corticosteroids increases. So the GINA strategy therefore recommends using different thresholds depending on the patient's inhaled corticosteroid treatment dose. They recommend 50 parts per billion or higher in patients who are inhaled corticosteroids naive, 25 parts per billion or higher in patients receiving medium dose inhaled corticosteroids, and 20 parts per billion or higher in those on high dose inhaled corticosteroids. But again, before we interpret a FeNO result, we need to remember that there are several factors that can influence the measurement. Let's start with the factors that can increase FeNO. The most important are atopy and allergic rhinitis, which can elevate FeNO even in the absence of asthma. Recent allergen exposure can also increase nitric oxide production, as also can viral respiratory infections, which may also transiently raise the FeNO level. On the other hand, there are several factors that can decrease FeNO. Smoking is one of the most important, which often result in an unexpectedly low FeNO value. Corticosteroids, as mentioned. Then also FeNO can be altered immediately after vigorous exercise or during episodes of bronchoconstriction. The key message here really is that FeNO must always be interpreted in the clinical context. A high FeNO supports ongoing T2 airway inflammation, but a low FeNO does not necessarily exclude asthma. Some patients, remember, have non-type 2 asthma, and others may have suppressed FeNO because they are already receiving corticosteroid treatment. So, a normal FeNO does not exclude asthma. It simply tells us that significant type 2 airway inflammation is unlikely at the time of testing. The next biomarker I'd like to discuss is total IgE. Unlike FeNO and blood eosinophils, total IgE is not a marker of ongoing airway inflammation. Instead, it is primarily a marker of the allergic asthma phenotype. Its most important clinical role is in identifying patients with allergic sensitization and determining eligibility for anti-IgE therapy, such as omalizumab. In a patient with confirmed atopy, total IgE helps us decide whether this biologic, this omalizumab, can actually be an appropriate treatment option. But we have to remember that IgE also has several important limitations. Firstly, it is a poor marker of asthma severity. Patients with mild asthma can have very high IgE levels, while patients with severe asthma may actually have normal or only modestly elevated IgE levels. Secondly, total IgE is not specific for allergic asthma. It can be elevated in many other conditions, including parasitic infections, eczema, certain immunodeficiency disorders like hyper IgE syndrome, allergic bronchopulmonary aspergillosis, and in some drug reactions. Finally, a single total IgE measurement does not reflect the current disease activity or current asthma control. Unlike FeNO, which changes relatively quickly with airway inflammation, total IgE tends to remain relatively stable over time. Another biomarker I'd like to discuss is allergen-specific IgE. Unlike FeNO, which tells us about ongoing type 2 airway inflammation, allergen-specific IgE answers a different question. What is driving the inflammation? It helps us identify which allergens a patient has become sensitized to, such as house dust mite, grass pollen, animal dander, or molds. This information is really valuable in patients with allergic asthma, as it can guide allergen avoidance strategies, support environmental control interventions, and perhaps identify patients who may benefit from allergy immunotherapy. But it is important to remember, a positive allergen-specific IgE test does not necessarily mean the patient is clinically allergic. It tells us that the immune system has produced IgE against that particular allergen. It demonstrates sensitization, not necessarily clinical allergy. That's why it is so essential to always take the patient's history. We always need to ask whether exposure to that particular allergen actually triggers symptoms of asthma. Only when the sensitization correlates with this clinical history can we really confidently identify the allergen as a driver of the patient's disease. So allergen-specific IgE can be measured using several different testing approaches. There are screening assays such as Fadiotopt, which are useful first-line tests, rule-in, rule-out test of allergy, and it determine whether a patient is actually sensitized to the common inhalant allergens. If screening is positive, or if the clinical history suggests a specific allergen, then you can do individual allergen-specific IgE tests like grass IgE, cat and dog IgE, alternaria IgE, house dust mite IgE, etc. More recently, multiplex assays such as ALEX have become available, allowing simultaneous measurement of IgE to hundreds of allergen extracts and molecular components from a single serum sample. So these comprehensive profiles are really valuable in patients with complex allergic diseases, patients with polysensitization, or when you need to distinguish between genuine sensitization versus cross-reactivity. But regardless of the testing platform used, you always need to take results and interpret it in conjunction with the patient's clinical history. The final biomarker I'd like to mention is sputum eosinophils, which is often regarded as the reference standard for assessing eosinophilic airway inflammation. Unlike blood eosinophils, which provide an indirect measure, sputum eosinophil analysis directly assesses inflammation within the airway itself. A sputum eosinophil count of more than 2 to 3% or greater is generally considered indicative of eosinophilic airway inflammation, and this is strongly associated with type 2 asthma. It provides a direct assessment of airway inflammation, really making it an excellent biomarker for phenotyping asthma and for guiding corticosteroid therapy. But despite being a reference standard, sputum eosinophil analysis is not widely used in routine clinical practice, and this is because the test is technically demanding. It requires specialized laboratory processing and experienced personnel. It is also highly time dependent. Samples should really reach the lab within 8 hours of collection to preserve eosinophil cell viability and to ensure an accurate differential cell count. But the good news is that this service is available locally at the Ampath National Reference Laboratory in Pretoria, allowing you to have access to this specialized biomarker. But you need to take into account the time restraints of this test. The obvious next question is, why do these biomarkers matter? One of their important roles is helping us select the most appropriate biologic therapy in patients with severe asthma. Each biologic targets a different component of the type 2 inflammatory pathway. For example, omalizumab is used in patients with allergic asthma and relies on evidence of allergen sensitization together with an appropriately elevated total IgE level. Benralizumab target the interleukin-5 pathway and are generally used in patients with elevated blood eosinophil counts. Dupilumab blocks interleukin-4 and interleukin-13 and is particularly useful in patients with high FeNO or elevated blood eosinophil counts. The important message here is not to memorize these individual biologics, but to appreciate that biomarkers help us match the right patient to the right treatment. This slide illustrates how we use biomarkers in practice to guide treatment selection. For patients with high total IgE, together with evidence of allergen sensitization, omalizumab is the option. Patients with elevated blood eosinophil counts, we are more likely to use targeted treatment to interleukin-5 pathways like benralizumab. If the predominant biomarker is high FeNO, reflecting interleukin-4 and interleukin-13 activity, dupilumab is an excellent option. But the real power of the biomarkers really lies in combining them. Patients with both elevated blood eosinophils and elevated FeNO often have the highest burden of type 2 inflammation. These patients tend to have more frequent exacerbations, they have poorer asthma control, and are often the ones who derive the greatest benefit from biologic therapy. I'd like to almost finish with a real clinical case that illustrates this perfectly. This was a 14-year-old girl with recurrent asthma exacerbations and poor symptom control. Her asthma control test score was 12, indicating poorly controlled asthma. Her biomarkers were striking, a FeNO of 183 parts per billion and a blood eosinophil count of 2.59. At first glance, this looked like classic severe eosinophilic asthma, and she appeared to be an ideal candidate for biologic therapy. However, before escalating treatment, we took a step back and we reviewed the patient more carefully. During consultation, we discovered that she had poor adherence to her inhaled corticosteroid therapy because she had read on social media that corticosteroids causes weight gain. Her biomarkers were actually accurately telling us that she does have persistent type 2 inflammation, but they were not telling us why. We spent time counseling her and her family, explaining that the weight gain is associated with long-term systemic corticosteroids and not with inhaled corticosteroids used at the recommended doses. So once her concerns were addressed and her adherence improved, her asthma control improved dramatically without the need for biologics. This case really highlights an important lesson. Biomarkers should guide our thinking. It should not replace it. They tell us that inflammation is present, but only careful clinical assessment uncovers the underlying reason. The right biomarker, interpreted in the right clinical context, leads to the right treatment. And sometimes the right treatment, the most effective intervention, is not a new biologic. It is patient education and addressing barriers to adherence. So this case brings us to one of the most important clinical reminders in asthma management. Before we label a patient as having severe asthma, we need to pause and we need to ask a few simple critical questions. Is the patient actually taking their inhaled corticosteroids as prescribed? Are they using the correct inhaler technique? Are they still being exposed to allergens or other triggers perhaps? Have we identified and managed important comorbidities such as allergic rhinitis, obesity, or gastroesophageal reflux? And perhaps most importantly, have we confirmed that the diagnosis is actually asthma? Our patient reminds us that uncontrolled asthma can easily mimic severe asthma. So before escalating to an expensive biologic, always stop and ask, have I optimized the basics? This slide summarizes how biomarkers can support us throughout the patient's asthma journey. Rather than thinking about the individual tests, I encourage you to think about the clinical question that you're trying to answer. First, does this patient actually have asthma? Here, FeNO and blood eosinophils can provide supportive evidence of type 2 inflammation. Next, is this type 2 asthma? This is where we start combining biomarkers like FeNO, eosinophils, and IgE. We can also use biomarkers to ask, is this patient at an increased risk of future exacerbations? Patients with persistently elevated FeNO and blood eosinophils generally have a higher risk of exacerbations. An important question, which biologic is most appropriate? And once again, the combination of biomarkers can help us there. And finally, is the treatment working? Biomarkers such as FeNO and blood eosinophils can be followed over time to monitor the response to treatment and help us to assess whether the airway inflammation is actually improving. So as you can see, biomarkers aren't just simply laboratory tests. They are really clinically relevant decision-making tools that support us at every step of asthma management. I'd like to quickly summarize the GINA 2025 strategy thresholds for your memory. In patients with severe asthma, a blood eosinophil count of at least more than 0.15, a FeNO of 20 parts per billion or higher, and sputum eosinophils of 2% or more, or evidence of clinically allergen-driven asthma. All support the presence of type 2. One important practical point. Remember, patients receiving high-dose inhaled corticosteroids may have suppressed blood eosinophil counts and FeNO levels. And for this reason, GINA actually recommends that blood eosinophils and FeNO may need to be repeated up to 3 times to avoid missing type 2 high asthma. Just summarizing the practical points, remember, blood eosinophils reduced by corticosteroids, elevated in parasitic infections, and follows the circadian rhythm. FeNO reflects interleukin-4 and interleukin-13 activity and falls rapidly with inhaled corticosteroid therapy, making it an ideal marker to actually assess whether the patient is adhering to treatment. Total IgE is useful for the allergic phenotype, but it's a poor marker of asthma severity. Before we conclude, I'd just like to reflect on how far we've come over the past 2 decades. Between 1999 and 2010, the focus was very much on the discovery phase, where we identified the key type 2 inflammatory pathways we identified these key cytokines, interleukin-4, interleukin-5, and interleukin-13. And during this time, the biomarkers were developed. Over the last 15 years, we've entered the era of clinical integration. These biomarkers have moved from the research lab into everyday clinical practice, where they now help us to make diagnosis, monitor response, and the selection of targeted biologic therapies. I just want to highlight that pheno testing is available through Ampath Laboratories, or it can be performed with your own point-of-care device, such as the no-breath analyzer. Pheno is currently offered at a number of Ampath care centres across South Africa, including Wilges Hospital and Life in Pretoria, Jean Avenue Care Centre in Centurion, Waterfall in Johannesburg North, Alberton in Johannesburg South, Ballito, St. George's in Kabarga, Panorama Mediclinic and Kingsbury Hospital in Cape Town, Centre de la Vie in Emalahleni, and Trichard Laboratory. If pheno is not yet available at your nearest Ampath care centre, please speak to your local Ampath marketer. They will direct you to your nearest care centre that actually offers it. And also, when there is sufficient demand and perhaps a commitment to regular testing volumes, you can also motivate for the placement of pheno area. A few practical points regarding billing. The pheno test is built as two components, the quantitative pheno measurement and the single-use no-breath mouthpiece, which has its own NAPI code. Patients currently pay for the test upfront, after which they can submit the invoice to their medical aid for reimbursement. The current cash price, including the mouthpiece, is approximately 479 Rand after the standard cash discount. I'd like to conclude with 6 key take-home messages. Firstly, most patients with severe asthma have type 2-driven inflammation. Secondly, the key biomarkers we use in clinical practice are blood eosinophils, pheno, total and allergen-specific IgE, and in selected cases, sputum eosinophils. Thirdly, biomarkers help us far beyond diagnosis. They allow us to phenotype and endotype a patient, estimate risk, select the most appropriate treatment. Fourthly, remember that combining biomarkers provide much more information. Fifthly, biomarkers should never be interpreted in isolation. It should always be considered alongside the patient's history, the examination, the lung function, the comorbidities, and the current treatment. And finally, before escalating to biologic therapy, always make sure you've optimized the basics. Confirm the diagnosis, assess adherence, check inhaler technique, identify ongoing allergen exposure, and manage their comorbidities. Thank you very much for your time. I hope that I've made it quite clear that these are not just laboratory tests, but really essential tools in the management of modern asthma. So, Andre, we have gone a little bit 3 minutes over our time, so there's perhaps not that much time for questions. I'm quickly going to scroll through some of the questions, and then we can see how we can answer them. The questions that we cannot answer right now, we'll definitely address and answer you personally via email. So a question from David. Regarding spirometry, as a general practitioner in a rural area, I can purchase and use a spirometer for basic lung function testing, including pre- and post-bronchodilator spirometry. My understanding is that pheno and metacholine challenge testing should be performed in a specialized lung function lab, as they require specific equipment and protocols. Would basic spirometry be sufficient for routine assessment and monitoring of asthma or COPD in a rural GP setting, with referral for pheno or metacholine challenge testing or full pulmonary function testing when clinically indicated?
So Sylvia, I think it's a great question. The issue is that spirometry is important. But what do we measure with spirometry? We measure airflow. And airflow limitation is the result of advanced inflammation and the consequences of inflammation. FeNO measures inflammation. So you can pick up the inflammation long before you actually see changes on the spirometer. And that is why spirometry alone is not regarded as good enough for an asthma diagnosis anymore. I showed in my slides that they want us to at least document two things. So with FeNO, you can actually pick it up before you see spirometric changes. And very often we've got a total normal spirogram, but the FeNO is high in that patient. It doesn't mean the patient doesn't have asthma. It's the reversibility on the spirogram that helps us more in diagnosing asthma. So as you said, the new NICE guideline says that if you've got an typical asthma-specific history, something we must talk about one day, what is an asthma-specific history, plus a FeNO in a child, that alone is good enough to diagnose asthma already. And I saw there was another question, when should we be doing FeNO? FeNO is not a specialized investigation. It's a GP everyday investigation. It's been used in research labs up to now, but it's now so well established that it should be rolled out to everyday clinical practice. And we should really do it before we actually start treating asthma patients. So in a wonderful world, and I'm not talking pediatrics now, if I've got a child and I wonder whether this child is asthmatic, yes or no, or even if I'm pretty sure it's an asthmatic child, I should document the FeNO and the blood eosinophil count before I start treatment. Because if I didn't document it before I started treatment, I wouldn't be able to have a reference to go back to when I need to adjust treatment or interpret future results. So we would like to document it as part of the diagnostic process, for example. So FeNO is something that's not reserved. Methacholine challenging, yes, that's specialized. And that should be done in a specialized lab. But spirometry and FeNO should be everyday practice. Eosinophils should be everyday practice. And I can tell you that in clinical practice, we do FeNO at Steve Biko Academic Hospital in the pediatric asthma clinic every day. We do it on a daily basis. And if you can't afford the machine, then one should send them to a central point to do the FeNO. And as you've seen, it's really not such an expensive test. I think it's wrong to commit a child to long-term steroid therapy without doing these basics before you commit them to long-term steroid therapy. And maybe just another point, and that's a bit radical, and I don't want to push that in South Africa, but in London at St. Guy's and Thomas's, if a patient comes in with an acute asthma exacerbation, they won't give steroids until they've done the blood eosinophil count and until they've done the FeNO. And only once they've done that will they administer the steroids. And I really want to ask people that sees patients and children, especially with acute respiratory distress, is this an asthma attack, yes or no? Please don't start steroids before doing the eosinophil count, because that eosinophil count will be gone tomorrow morning after one dose of steroids. And if we know before we gave the steroids the eosinophil count was high, then we're more certain that we were actually dealing with an acute asthma attack and not with a virus infection.
Andra, I've got also two questions that actually comes down to the same thing. Doctors wondering when they actually now want to do FeNO or eosinophil count and the patient was on corticosteroid therapy. How long do they need to wash out this patient before they can test? What is the washout period?
So this is now, what is my pre-test probability? If the patient had steroids, and I'm more talking about systemic steroids, oral steroids. If a patient had oral steroids, I can't trust my eosinophil count, definitely immediately or short term after he's had his oral steroids. Sylvia, I'm not sure of how long you really need to wait after oral steroids before you can trust the eosinophil count. Do you have an idea? I don't.
No, it's about 2 weeks,
2
Andre.
weeks. 2 weeks, yeah. So that's what we normally do, about 2 weeks after oral steroids, before we trust the eosinophil count. To give you an idea on what do steroids do to pheno, the patients come in with a high pheno. We check their technique and we give them steroids. They've got an exacerbation, and literally within days, the pheno drops after you've given the steroids. So if it's a T2 inflammatory process, the pheno drops. So, but on inhaled steroids, we use pheno to monitor, first of all, their adherence. Do they really take the inhaler? And we use to monitor how strong the inhaler should be. And one of the most helpful things in the clinic is to wean them off their inhaled steroids, to reduce the dose of the steroids. So we've got a patient with asthma. Before we started treating him, we did his baseline pheno, we did his baseline eosinophil count. We know what it was before. That's what our diagnosis was based on. We introduced him to a steroid-containing inhaler. He comes back for follow-up, and his pheno has dropped into the ground. And we now know that inhaler is working, and we know that we could even reduce the dose or the strength of the inhaler. We can wean them to a lower dose. So we use pheno on a daily basis to actually adjust the doses of steroids that we are giving.
Andre, there's a couple of therapy-related questions. I think, treatment in asthma is a whole lecture actually on its own, and perhaps one day you've got an excellent lecture on the treatment of asthma, and I think you should give us that lecture. But let's just address 2 or 3 questions here. Any benefit of combined use of inhaled steroids with stimulates with steroids?
Inhaled? Sorry, I missed that, Sylvia.
Inhaled stimulants combined with steroids.
So with stimulants, I suppose we're talking about bronchodilators. No.
Bronchodilators, yes.
Yeah, so remember that the GINA guidelines currently advise on first-line treatment for asthmatic patients, and these are now children 5, 6 years and older, is a combination of lower dose inhaled steroid and formoterol. And formoterol is a rapid onset, long-acting bronchodilator. That's also a controller and a reliever, and that is currently globally accepted as the ideal treatment to prescribe on a chronic basis and use the same medication as reliever therapy. In other words, whenever you've got the flare-up of symptoms, in time, early, give additional inhaled corticosteroid and the bronchodilator with it. And that is what's referred to as air therapy. And it's been well documented. If you've got a patient on a baseline maintenance treatment with a bronchodilator, with formoterol and with budesonide, and it's already on maintenance treatment, and now there are flares up, symptoms are flaring, early when the flare starts, give additional inhalations, and that additional inhalation should contain extra steroid, like in the formoterol combination with budesonide. And if you combine that early, you reduce the need for hospital admission, you reduce the need for oral steroids significantly. And that's why it's now advocated as first-line treatment. So we really need to give additional inhaled steroid with our bronchodilator early to avoid the need for oral corticosteroid courses. And we now know that oral corticosteroid courses, short courses, are not innocent. We thought they're innocent, they're not innocent. They've got immediate consequences in patients, but the cumulative lifetime exposure. In other words, if I take repeated courses, short courses of oral steroids, it's got long-term consequences. And the new GINA guideline that you've quoted actually says that in a patient where you're prescribing a short course of oral steroids, if you do it repeatedly, there should be informed consent, especially if you're giving the patient more than 4 courses in his entire life, the short courses of steroids. There should be informed consent, but we can talk about that on at a later time. So we should really prevent the need for short courses of oral steroids, and FeNO is so helpful in doing it.
Thank you, Andra. I think we've run out of time. People need to go and see what Argentina is doing against Egypt. The questions that we have not addressed, we'll answer personally via email. Thank you, Andre, for joining us tonight, for your brilliant talk, and thank you for everyone joining us tonight. I hope that you've got a good evening. Good night.
Thank you, everyone. Good night.
Thank you so